everybody. For those of you I haven't met, my name is Pedro Chavez. I am the senior CICT for Team 22, Team Blue Magic, and I just wanted to thank everyone for joining us today. I am grateful to have you all as our honored guest. And before I start, I just wanted to share that working on this presentation has helped me seeing things from a different perspective, and I hope that this presentation is informative and helpful and you can learn a thing or two. Now, my presentation today is on health inequities in racial and ethnic minority groups. And the very first thing I wanted to do was I wanted to start us off with some definitions. First, I have the Oxford definition of inequity, which is the unfair difference between groups of people in society when some have more wealth, status, or opportunities than others. Now, how does this translate into health inequities? Certain communities, especially communities of color and indigenous communities, have higher rates of preventable disease and death, not due to genetics, but due to zip code, gender, income, and race. So I thought it was really important to understand these definitions as the complete presentation is based off of them. Now, while preparing this presentation, I was able to find a lot of studies indicating that over the course of the pandemic so far, one of the biggest trends that has emerged is how the impacts of COVID-19 vary widely by race and ethnicity. Before we get into this health inequities and this impacts across different races and ethnicities, I wanted to show you and present you with the following information in this specific way. Let's start with these two graphics. The one on the left is a chart of US positive COVID cases, and it's classified into race and ethnicity. Note how race and ethnicity was available for about 51% of all of those cases. And let's move into the graphic on the right. This graphic contains information about death rates from COVID, and it's also classified by race and ethnicity. Note how race and ethnicity was available for about 76% of all those deaths. Now, when we look at both of these charts and we sort of go back and forth in between them, the changes between positive cases and death rates aren't very noticeable. For example, you can see Hispanic and Latinos hold about 20% of total US race and ethnicity identified cases. And when we go across, we can see how about 12% of US race and ethnicity identified recorded deaths are Hispanic and Latinos. Next, we can see Native Hawaiian or other Pacific Islanders, and this race holds about 0.4% of positive cases. When we go across, we can see how they hold about 0.2% of identified recorded deaths. So there aren't really any noticeable differences or changes between cases and death rates. And yes, you might be asking yourself, you're telling us minorities are affected more. Why is this chart showing us something different? And I do see in myself the white non-Hispanic race still makes up the largest percentage of both cases and death rates due to COVID. With that said, based on this information from the census, we can see how white people also make up more than 76% of the total US population. So that would explain why this race has more cases and deaths. And when the information is presented this way, it's harder to really see and understand these health disparities. Now, I was able to find a study by APM Research, and what they do is they use the latest population estimates and they calculate rates and percentages and they put that data into a format of amount of deaths for every 100,000 people from a specific race. So here we have the US mortality impacts from COVID-19 for all race groups since the start of the pandemic. Now let's go back and really try to understand this study. The first would be the most affected race, and this shows about 210 deaths per every 100,000 Indigenous American, or 1 in every 475 has died. Next one down, we have 155 deaths for every 100,000 Black American, or 1 in every 645 has died. And next down the list, we have 150 deaths for every 100,000 Pacific Islander, or 1 in every 665 has died. Next one down the list, we have 120 deaths for every 100,000 white American, or 1 in every 825 has died. Next one down the list, we have 119 deaths for every 100,000 Latino American, or 1 in every 835 has died. And last on the list is 75 deaths for every 100,000 Asian American, or 1 in every 1,320 has died. Now, when we look at the information this way, we can see how the most affected minority is dying at a 3 times higher rate than the least affected minority. So when we look at this data and this perspective, we can definitely see how COVID-19 is having hugely disproportionate effects on the Indigenous, Black, and Pacific Islander communities compared to their population percentage. So the question I asked myself was, what's going on? Why are people of color dying more? Now, I found out data that shows that the healthcare system is not fair for all people that come its way, and it's certainly a bigger problem than I ever imagined. So I also found this study by the CDC that shows factors that contribute to increased risk of COVID-19. These factors are discrimination, healthcare access, education, occupation and income, as well as housing. And so we're going to go over some of these risk factors, starting with discrimination. I don't think I have to lecture anyone on discrimination. It is the sad reality of this country. And unfortunately, discrimination exists in the healthcare systems. The healthcare systems that are supposed to have the community's best interest at heart. Discrimination, which includes racism, can lead to severe stress or fear of seeking out medical assistance that might put some people from racial and ethnic minority groups at increased risk of COVID-19. Now, while doing some research, I found many videos from people that have recorded their experiences with racism while seeking out for help with their health. So there are some real life experiences out there, and I thought of sharing a couple of them with you. So I have a little video, and I'll play the first half. The first half is on a doctor, Dr. Susan Moore, who actually died of COVID-19 complications. On her video, she talks about some important key factors of her experience with racism. So I'll play the video and I'll come back.
At that time, I'd only received 2 treatments of the remdesivir. He said, you don't need it. You're not even short of breath. I said, yes, I am. Then he went on to say, you don't qualify. I must have, because I've gotten 2 treatments. And then he further stated, you should just go home right now. And I don't feel comfortable giving you any more narcotics. I was in so much pain from my neck. My neck hurt so bad. He made me feel like I was a drug addict. And he knew I was a physician. I don't take narcotics. I was hurting. You have to show proof that you have something wrong with you in order for you to get the medicine. I put forward and I maintain if I was white, I wouldn't have to go through that. This is how black people get killed. When you send them home and they don't know how to fight for themselves. I had to talk to somebody, maybe the media, somebody, to let people know how I'm being treated up in this place.
And I know this video is very heartbreaking, and I thought it was important to include it because sadly, this is the reality for so many people. In regards to the doctor, somebody who knows the type of care that she should be receiving, somebody who is able to fight for her health, um, made me think of what about everyone else? What about regular working people? People who are trusting their lives to the healthcare system. She made a really powerful statement that really resonates with me. How she mentioned this is how Black people get killed when you send them home and they don't know how to fight for themselves. The doctor also brings to light another topic that I also saw while doing some of the research, which is studies that show Black people receive poor treatment when it comes to pain management. And this is not recent, but it dates back to slavery and colonialism. And we have seen this on other presentations, and it's just really sad to see that these harmful and lingering effects still exist on today's society and in today's healthcare. Now, I would like to continue by playing the next part of the video. This is a report and it shows two members of the Indigenous American communities. And I'll play the video and I'll come back and comment on it.
Michelle Lebrec was recently found to have a fractured pelvis, but it took 3 trips to hospital before she received that diagnosis.
You're not treated as well as like the white people that come in, and a native or just seem to be turned away.
Not her first bad hospital experience. Once, she went to see a doctor about stomach pain. They discussed her drinking problem and homelessness. He gave her this. When she complained, the hospital apologized, but she felt humiliated.
Discrimination against Aboriginal people is, in fact, pervasive in the healthcare system, according to this new study, which says ongoing racism has had a major impact on Aboriginal people's health.
The study found Aboriginal people often just avoid medical care to avoid discriminatory treatment.
Some other medication that I take and use.
Carol McFadden put off breast screening for years after a doctor suggested she needn't have come to a clinic for examination. She recently discovered she has stage 4 cancer.
You're somebody that's wasting their valuable time that they could be spending on, somebody else more deserving of the healthcare system.
So I also found this video very heartbreaking and very hard to watch. And I know their experience wasn't related to COVID-19, but I thought it was important to share the video as well. It makes me think that these community members are a perfect example of how a failed healthcare system has completely shaped their mentality. And, they mention things like, I'm not worth healthcare, I'm not worth them spending time on me when they can be seeing somebody else. And, the video also talked about how Indigenous people often just avoid seeking medical treatment, just to avoid discriminatory treatment. And these are just 3 of many, many different experiences that are documented out there. Some other studies talked about the level of care that some physicians treated people differently based on their race, cultural differences, and unconscious biases. The next risk factor I wanted to talk about is healthcare access. Some people from racial and ethnic minority groups are more likely to be uninsured, I know this because I didn't grow up here in the US and I didn't really know about insurance through my family. It wasn't until later on when I became a responsible working adult that I learned about all the benefits from healthcare access and insurance benefits. Also, people without insurance would rather not look for medical assistance to avoid those large bills. And it's just sad that every day when people can't pay for healthcare, people are literally dying because of it. Also, good healthcare might not be available in some poor neighborhoods and easily obtained in others. Healthcare access can also be limited for this groups by many other factors, such as lack of transportation, just fear that exists on people who might not have legal documents to be in this country, access to childcare, lack of information. People might not know where to go to find resources, communication and language barriers, cultural differences between the patients and the providers, as well as historical events. I think we have also learned through our trainings about many historical events that can put mistrust on the healthcare system for some races and ethnicities. The next risk factor I wanted to talk about was education. Inequities in access to high quality education can lead to lower high school completion rates, which can then be barriers to college entrance. This might limit future job options, which can then lead to lower paying jobs or less stable jobs. People with limited job options are likely to have less flexibility to leave their jobs. That might put them at higher risk of exposure to the virus. People in these situations cannot afford to miss work even if they're sick, as they need to work for essential items like food, rent, bills, or they're the only ones who provide for their family. The next factor that contributes to increased risk of COVID-19 is occupation. I think working on this job, we have been able to have an insight on people's employments. Some people from racial and ethnic minority groups are disproportionately represented in essential work settings such as healthcare facilities, farms, retail, factories, grocery stores, and public transportation. Some people who work in these settings have more chances to be exposed to the virus due to several factors such as close contact with the public or other workers, or not being able to work from home. Did you know that only 27% of people in the US are able to work from home? Now, we have this chart on our right and it's based on the risk score across different professions. And you can see how the higher the pay, the lower the risk, and how the lower the pay, the higher the risk. Next, I have a zoomed in version of that chart. And here we can see a little bit better. So we have blue circles for non-healthcare related jobs. We have green circles for healthcare related jobs. And up here we have our key. And so we can see the smallest of the circle accounts for about 100,000 people in a particular occupation. And as the circle grows, the larger the number gets. The largest of the circle stands for up to 5 million people in a particular job or occupation. And that brings me to my last risk factor, which is housing. So some people from racial and ethnic minority groups live in crowded conditions, and in some cultures it is common for family members of many generations to live in one household. I remember that I worked a lot with a lot of Hispanic cases when we were in search, and I remember that this is definitely the case. I remember this one time where a case told me that it was a household of 9 people that share a one-bedroom apartment. And so it might be difficult for these people to follow the appropriate isolation guidelines. And all these and more other factors are associated with more COVID 19 cases, hospitalizations, and deaths. And I also wanted to touch base on something that I also thought was important, which is genetics. So there are genetic factors that play a role into how severely someone can be affected by COVID 19, um, more in regards to underlying conditions that might make it more difficult for you to handle or recover from this disease. And there are a lot of ongoing investigations happening at the moment as we speak. And, it's difficult because there are still numbers that are missing, stats missing, both for accurate case counts, race and ethnicity information. So we're still learning a lot from the virus today. But studies so far indicate that we will not discover at the end of the day that this health disparities can be attributed to genetics for for the most part. And so my question to you guys is, if race doesn't predetermine our health on a genetic level in the vast majority of cases, then what accounts for the racial health disparities that we see in data across the US? What accounts for infant mortality rates being almost 3 times higher among the Black population than in the least affected populations? What accounts for pregnancy related mortality rates almost 3 to 4 times higher in Black populations than in any other populations? These being deaths due to complications during birth or based on the level of care that the Black mothers are receiving. We can also see that the Black populations also have the highest breast cancer mortality rates. These also repeats itself across data from cervix cancer mortality rates. We can then take a look into new HIV diagnoses that are also led by the Black American population. We can also see how cardiovascular disease diagnoses are also led by this race. I think this pandemic is the perfect lens through which we can see that health is not so much about our actual bodies that we live in, but the social constructs that are imposed on those bodies. Health is determined by our access to healthcare and education, your race, what your gender is, what language you speak, how much money you make, whether you can afford to take time off work to be seen by a doctor, whether you live alongside a lot of people or just a few, whether your job requires you to interact with a lot of people, and how your healthcare provider is going to treat you. So I see a deeper meaning to the work that we do, especially when it comes to our questions about race and ethnicity. It's through contact tracing that we can prevent the spread within those populations. It's also through contact tracing that we can provide resources for the best possible chance. The resources do exist, and we can play a big part into providing information and preparing these people for the best outcomes possible. It's also through providing isolation guidelines and just being very thorough that we can potentially save somebody's life. And also, it's because of data collection that this information is available to the public. Data that is analyzed and studied to make progression, to make changes, and to be able to approve policies um, that can then help us understand and act against these disparities across races and ethnicities. That brings me to one of my last slides. What can we do long term? We can start by speaking out and stand for what's right. If you're in a position to speak against racism, not only in a healthcare setting, but in any other setting, please, um, please do so. We can ensure equal access to healthcare and eliminate any discriminatory practices against racial or ethnic groups. We can prioritize access for free or affordable testing, medications, and needed procedures for those at higher risk. We can involve communities and their representations and associations in designing and implementing health programs and projects concerning racial and ethnic groups. We can make wider use of mobile clinics to reach out and deliver services directly to marginalized and vulnerable communities who might be cut off from access to healthcare services. We can distribute essential medical and preventative information in minority languages through digital and printed means. Last but definitely not least, we can increase awareness of racial and ethnic disparities in healthcare among the general public, just as we're doing now and as we have been through these presentations. And the last message that I wanted to send across was if you have come into work and you've prepared yourself, you've learned on how to deal with difficult questions for somebody's concerns about answering any of our questions, you have helped and you have done your part, and for that, I thank you very much. That is the last of my slides. I do have a couple of slides with citations, and I would also make this PowerPoint available if you're interested on teaching these to somebody else. And I look forward to meeting all of you during the coffee hour and answer any questions that you might have encountered. Thank you all so much for your time today.